This week on the BackTable podcast.
From the beginning, organically, I wanted to make sure that the patients had a clear point of access to the institution, a clear person to help them navigate the very complicated multidisciplinary care that we're going to need for head and neck cancer. But knowing that inequity in long-term follow-up is an issue impacted by social determinants, that is a focus for Donna, is to assess patient follow-up, assess when I have said they need their MRIs and staying on top of it for them. We always have this sense that when the cancer is treated, everyone takes their breath and is like, good, we're past the danger. We're out of the danger zone. But actually, we have specifically paid attention to the long-term follow-up, the compliance with follow-up regimens, with imaging regimens and whatnot. And we have specific time that Donna dedicates to keeping a running look at that for all of our patients to try to proactively prevent some of the social determinants from impacting a patient's ability to follow up with us.
Hi, everyone, and welcome to the BackTable ENT podcast, where we discuss all things ENT. We bring you the best and brightest in our field and hope that you can take something away from our show to your practice. My name is Anthony Sheyn, and I'm taking guest hosting duties today from Gopi Shah and Ashley Agan. I'm the Pediatric ENT Chief at St. Jude Children's Research Hospital and Bonheur Children's Hospital. And today with me, I have Dr. Jeffrey Rastatter from Lurie Children's Hospital and Dr. Danny Chelius from Texas Children's Hospital. Go ahead, guys, introduce yourselves, and we'll get started looking at how social disparities impact health outcomes in adults and children regarding cancer.
Thanks, Tony. I'm Jeff Rastatter. I'm at Lurie Children's Hospital in Chicago, Ann and Robert H. Lurie Children's Hospital of Chicago. That's what they like us to say. And Northwestern University. Even though Tony is playing host duties here, filling in today, he's absolutely kind of one of our crew we've been working with. And some of you may have heard our previous podcast, the three of us did together, talking about development of pediatric head and neck cancer centers of excellence. And so we're excited and honored to be invited back to speak again. So thanks everyone for listening.
Thanks, Jeff. I'm Danny Chelius. I'm a pediatric otolaryngologist at Baylor College of Medicine, and I practice pediatric head and neck surgery at Texas Children's Hospital in Houston, Texas. And I'm ecstatic to be back here at BackTable with everyone. And I do want to point out that Tony is definitely the best and Jeff is the brightest, which leaves me as the palest. So best, brightest, and palest. And that's doesn't come across well in radio, but I promise that's the reality.
Well, thanks for being here, guys. And today we'll be talking about social disparities and social determinants of health. Let's start off first. What are social determinants? I know we've been working together for about 5-6 years. I was trying to do the math of when we actually started working together. And I think it was when Academy was in Chicago or Atlanta when I came up to you guys during a lecture. And I think most of our research has been on looking at pediatric head and neck cancer, starting with thyroid cancer and expanding. But lately, we started looking at social disparities. So what are social determinants and why are they important?
I think most medical schools at this point have classes or tracks to formally educate students on social determinants of health. And I think it's a wonderful thing because as I was coming up through medical school, it was something we were all aware was an issue, but we didn't have formal training in how to examine for and assess for social determinants of health in an organized fashion. And so now we see curricula, we see formal education for medical students and residents around considering and assessing social determinants of health. So I would broadly define social determinants of health as those aspects of one's life that are not directly biologically, physically related to health, but that impact your ability to access and collaborate in your healthcare with the medical system. Things like your economic status, things like your geographic location, your physical access to healthcare settings, things like your language, your primary language. Are you speaking the language of the healthcare system where you live, or do you speak a different language as your primary dialect? Things like your transportation status. Do you have ready public transportation where you live or personal transportation? Or are you working with a transportation status that is different from the overwhelming community that you're in. These are the types of things that we know can drastically impact access to care, your ability to collaborate with your care providers, to follow treatment recommendations, to buy medications, to have care for your children when you're attending your own appointments or when you're taking one of your children to an appointment that the other children can't come to. And so we know now to ask about these social determinants on an individual level with our patients, and we can assess for these social determinants across broad populations of patients to try to identify trends that can show us how social determinants are either aiding care or are being detrimental to a patient's care. And that's how I would broadly define it. Jeff, anything to add to that?
Danny, I think that was a great, synopsis or summary of social determinants. And we could probably just talk this entire episode on all of the aspects of social determinants and what sort of factors can play into overall delivery of care. It's interesting when I first started seeing papers coming out looking into how things such as social determinants would play a factor. It kind of started out as we would look at papers and we would look at insurance status. Did people have private health insurance or public health insurance or no health insurance? And how does that impact overall care? That was my sort of first experience with papers. That I'd love to hear, Tony and Danny, what yours was. But it seems like from the time it sort of began there, it's just really developed into a much broader field in terms of what are the various variables we can look at. I think those early papers looked at insurance status just because the information was there. We could look at databases and we had that information. But now what we're seeing is lots of additional information in this broadly described as social determinants of health are being recorded such that we can now look at this larger scope and just get more granular detail as to what factors are associated with. I'm being careful with what words I choose because we have to be careful not to assign cause and effect to something without proper research to assign cause and effect. But we're starting to look at associations between some of these social determinants and outcomes and how people are cared for. Ultimately, with the next step going to be to start to try and answer the questions of why are things the way they are, and are there ways we can change the way we deliver healthcare, both related to social determinants and other factors, in order to optimize everyone's care and outcomes.
You asked what I was sort of first aware of in terms of the papers. It's really startling to think about the level of awareness I had of this as a young medical student versus now, 20 years later, how much of an organized approach the data science can take to social determinants. As a medical student, reminds me of that old question or the story of, someone asks a fish, "Hey, how's the water?" And the fish is like, "What's water? What are you talking about?" Not able to appreciate that water is literally the thing that makes it possible for anything else in that fish's life to happen, but the fish doesn't have a concept of it because they're just swimming around in the water. Well, I think we swim around in the milieu of social determinants of health, and all of our patients do. And I think we were organically aware of it. And the first organic awareness I had of it that I can easily remember as a medical student was watching the differential access to renal care for patients with different sorts of insurance, and in particular, different legal status here in the United States. At the time, I was a young medical student. We're reaching back 20 years ago. And I would watch people in different systems get very different access to dialysis, very different timing of dialysis, depending on a very obvious set of factors around their economic status, their insurance status, their ability to travel to the hospital for care. And in the worst case scenario, people who would only be able to get dialysis when they were absolutely in an emergency situation, dying. And all these patients had the same underlying disease, more or less, and had the same need for dialysis, but the discrepancy in their access to care was very obvious to me as a young medical student. As an ENT resident, it was very obvious when we looked at head and neck cancer care in different settings. The radiation machines, basically the same, but the ability to get a patient to the machine completely affected by their ability to travel, their economic resources, their ability to take time away from their work, their language status in our different healthcare settings that I was seeing between a county general setting, a private cancer hospital setting, a privately insured hospital setting, a federally funded healthcare setting. Very different access to the very same radiation for the very same head and neck cancers. And that was obvious as a medical student, but not as very carefully described and researched as it is in the current level of papers that we're looking at now in the type of evidence that we have now.
Tony, what was your earliest memories of starting to think about social determinants of health before it was even called social determinants of health?
I became really aware of this as when I was a young attending, and we had a fair amount of no-shows, and I would call them and say, hey, you all missed your appointment. It would be like, oh, because our car broke down, or we didn't have enough money for gas, or we missed the bus. And we've made some accommodations to try to get patients who have socioeconomic issues in at different times and be very accommodating to them. But it's not until recently that we actually started working on this as a group and try to kind of approach this from a group standpoint and roll it out on a national scale once we finish our work. So I just want to ask you guys, for the audience, how did we get started on this? And talk a little bit about our research that we're doing this right now.
I can comment on that, but there's a couple of things that, I think that Tony, you mentioned that 5-6 or so years ago, it was that the three of us started working together just in general based upon common interests in taking care of pediatric patients in general, but specifically head and neck tumors, both benign and malignant. Yeah, and so we started looking at disease processes. But along the way, I think that the social determinants of health kind of found us, really, because we were doing the work of studying the biology of tumors in these kids, and part of it, I think, was just a movement in general to where social determinants of health is being looked at in a lot of fields, including ours. So it started to make its way toward us like that. But then it really sped up and got going when we met David Fei-Zhang, who is a medical student at Northwestern University Feinberg School of Medicine here in Chicago. And he currently is a second-year medical student, but we've been working with him for a couple of years. He reached out to me through a couple of other contacts when he was at Mayo, prior to his time at Northwestern. And so in getting to Northwestern, he had just expressed an interest in otolaryngology research, pediatric otolaryngology research, and he had an interest in studying social determinants of health. And so he brought the idea to us as well. So a combination of just a general movement and then David, coming to us with his ideas. And I have to say that, we get approached by medical students, residents, fellows all the time looking to be involved with research. And in general, we come up with projects for them. David has been different in that he is really kind of punching above his weight, so to speak, in that in social determinants research, he's really leading the charge. And I think that both Danny and Tony would agree that all three of us, while we have certainly played mentor roles with David, he's taught us a lot in terms of some of this work. And some of the work we'll talk a little bit about today that we've been doing in terms of contributing to the field has been methodology that's very much been described and written and created by David through his hard work and perseverance with research. So that's I'd say that's how we sort of got into it. And it's been a couple of years now of a lot of work, and some of the papers are starting to go into publication now. And we're seeing those contributions out there, but it's been a couple of years now working with David and several other students along with the three of us.
I have to say that getting to meet David and see his intellectual approach to this research has been eye-opening for me. There have been a number of papers over the years looking at how any one of these social determinants individually may have some degree of impact on a disease process. There have been countless publications to that regard. But the beauty of the approach that David takes and that we have now taken in our research is to actually look at the interrelatedness of all of these different social determinants in a more organized fashion. This is not, for the most part, intuitive. We can guess what social determinants are going to affect access and care in certain ways, but you would think that a medical system full of people with good intentions, good hearts, who want the best for their patients would be able to anticipate the way the social determinants are going to affect us and which ones are the most important, and then fix them and have a simple fix for it. And the reality is, we all know that's not the case. And so the thing that I really appreciate about David's approach is it takes a very comprehensive look at a lot of different social determinants, how they interact, and can sort of point us in the direction where we can make an impact based on the findings in a more robust way than any individual social determinant examination can.
Yeah, that young man's going to have his pick of ENT programs when he's ready to apply.
Trying to make it so his car doesn't work so he can't leave Chicago.
Well, I'm ready to buy him a plane ticket to come do an away here.
I already have a house for him. I'm sorry.
In the work that we've done, what has been found how social determinants negatively impact health outcomes in general, and specifically in the pediatric populations that we have been looking at? What have you guys found?
I can start it off by just saying one thing we've noticed is we've looked at the number of months, or basically the time that people are being treated. What do we see with that? And when you look at social determinants as a whole, and by the way, we can get into a little bit of what these social determinants are, because some of it has to do with the social vulnerabilities index, which is, as Danny mentioned, a more comprehensive way of looking at social determinants of health. There's 4 different pods, if you will, or buckets of social determinants, each with several related factors in there. We can go into more detail on that, but to get back to just the amount of time that people are surveilled with different tumors, and we find that as their vulnerability score increases, meaning they have more of these categories or factors or variables that are seen as social determinants that negatively affect their outcomes, they're surveilled for a shorter period of time. And it's interesting. I think that we have to, research, one bit of research always leads to the next. I think we're now starting to have to look at, well, why is that? Is that they're being found later because they had poor access to healthcare and they were diagnosed at later stages? Is it that after they get diagnosed, they get kind of some level of treatment and then get kind of lost to follow-up compared to people that are less vulnerable? It would behoove us to figure out why if we want to optimally treat these patients. But what we know now is that people who are more vulnerable, as measured by these social determinants of health, are being cared for, treated, and monitored for shorter periods of time than patients who are less vulnerable.
I think we also have seen that for certain diseases we've looked at in pediatric head and neck cancer, increasing social vulnerability across these different themes, which I can summarize in a minute, but increasing social vulnerability has been associated with presentation at a more advanced stage and with, frankly, decreased long-term survival. Now, this is across a population. This is generalized. It's not speaking to any individual patient. And there are certainly going to be exceptions to this. And so, but we see the smoke. When obviously where there's smoke, there's fire. I can just describe briefly the different theme areas that we look at with the social vulnerability index. There are basically 4 different themes. The first one is socioeconomic status, and things that factor into socioeconomic status include the poverty in a given geographic area, unemployment levels in the area, average income levels in the area, and high school diploma status. So those all factor into the bucket of socioeconomic status. The second theme is household composition, which would include household members greater than 65 years old or household members who are under 17. So basically at the extremes of age. Disability status of members of the household, and single parent status in the community. So things that will affect the household composition. The next major theme is housing and transportation. And that includes the number of multi-unit structures in a given geographic area, a number of mobile homes, evidence of population crowding in an area, evidence of personal transportation availability, whether or not someone has a vehicle on average in the population area, and then the group quarters, so to speak, like the basic different living structures that people are associated with. And then final bucket is minority and language status. So whether or not someone is in a minority, racial or ethnic group in the area in which they're being cared for or by the system that is caring for them. In general, that would include American Native or Alaskan Native, Asian, Black/African American, Asian Pacific Islander. These are groups that have been defined as minority status by multiple different Institute of Medicine and CMS standards. And then proficiency with English. And when this is rolled out in other populations, it will be proficiency with the language of the healthcare system where they're receiving care. So these are the different thematic areas, and we can take the social vulnerability index in a given locale and match it to the data reported for pediatric cancers in that locale to get a rough estimate of the social vulnerability index in the location where the patient is being treated. Now, most of these studies are not looking at the specific social vulnerability index of a specific patient, but are applying the SVI of their locale to the disease that's being treated, to where it's being treated. So, for example, I found it was very interesting. I would expect or anticipate that minority status and language composition, specifically language, would have had a bigger impact, detriments in care, than it turned out to have in most of our diseases examined. For most of the pediatric head and neck cancers we looked at, language status actually was not a severe detrimental factor. But when you consider the institutions that are contributing to the SEER database or to the databases where we're pulling from, many of them are in areas where minority language status actually is not that much a minority. For example, Spanish in Texas or Spanish in Southern California. And so it makes sense that perhaps the healthcare systems there are better adapted to compensate for, to non-primary language status, and are actually compensating well for that factor. So, for example, then, I might take that information from the study as I'm thinking about how to make a difference for my patients and put my resources not into more language access, but perhaps into other social determinant improvements amongst my patient population.
Looking at the work that we've done, actually, I've given several lectures on this. I look at it as a positive, why minority and language status doesn't seem to be too impactful. And I look at it as a positive that the medical schools are doing a really good job in diversity training of our future doctors so that there is more focus on that. So
yeah, that's a wonderful story, Tony, right?
Yeah.
Like that is something awesome to take home from all of this.
So one of the lectures I gave was actually at our diversity seminar that was led by several of our medical students, one of whom the leader just matched at the University of North Carolina Chapel Hill program. So they got themselves a wonderful future resident and future leader.
I do want to hop in there for 1 second though, Tony, and it's obvious to the three of us, but I want to make it very plain to the listeners that we're looking at the social vulnerability index for specific pediatric head and neck cancer diseases. This is not to say that the House of Medicine in general is equally successful in minority and language status equity across all disease states and all patients. And we know that there are still, for example, huge inequities in terms of maternal care, maternal fetal care. And so I think we have to be very granular with what we are applying the social vulnerability index to and what we're talking about so that we can be vigilant to try to continue to make improvements.
That's absolutely right. While there has been a lot of positive steps, more can and should be done on this topic as far as other fields of medicine.
I think that's right. And I think we also have to be aware that all of this is observational research, and we're sort of looking at these cross sections or snapshots or windows, however you want to say it, as to what's going on. But more work and thought needs to look into the why of some of these things, because it's not always immediately obvious in some situations as to why one particular factor might be associated with better or worse care than another particular factor. I think one thing that is fairly clear is if you can't access the medical system, you're certainly not going to get the benefit of that treatment. So some of these factors more directly relate to access to care, transportation, for example, insurance status, for example, and some others. So I think that this access to care for a while was a big word people were using. I hear that word less now, and we hear more of this kind of social determinants of health and so on. But access to care is most certainly of significant importance within this topic that we're talking about. So in terms of like what the actionability or what can we do about some of these observations we're seeing, I think one of the things I tend to think about are which of these factors that we're seeing that are leading to poorer outcomes or problematic treatment are related to access, and can we improve that for certain groups of people?
So, on that topic, are there any specifics in the work that's been done that has stood out for you in terms of a specific tumor type or a specific population type, which you feel may be an actionable item that you can implement?
So organically, before we had this data demonstrating the poor follow-up for some of these diseases, we already had the sense that an important component of my multidisciplinary head and neck cancer program was going to be a care coordinator. And I have a spectacular care coordinator named Donna Layton. She's a nurse here at Texas Children's. And, from the beginning, organically, I wanted to make sure that the patients had a clear point of access to the institution, a clear person to help them navigate the very complicated multidisciplinary care that we're going to need for head and neck cancer. But knowing that inequity in long-term follow-up is an issue determined by impacted by social determinants, that is a focus for Donna, is to assess patient follow-up, assess when I have said they need their MRIs, and staying on top of it for them. We always have this sense that when the cancer is treated, everyone takes their breath and is like, good, we're past the danger. We're out of the danger zone. But actually, we have specifically paid attention to the long-term follow-up, the compliance with follow-up regimens, with imaging regimens and whatnot. And we have specific time that Donna dedicates to keeping a running look at that for all of our patients to try to proactively prevent some of the social determinants from impacting a patient's ability to follow up with us.
I was going to say something very, very similar, that I think the biggest change in my practice that relates to access is the development of the multidisciplinary team. I know where my expertise is in terms of the role that I play in caring for these patients, but what I do is not enough. If I can't get that patient to my office or get that patient to the operating room, or they can't get to the chemotherapy center, then we can't do our jobs. Physicians can't do their part. So the couple of groups of folks that really come to mind and on our multidisciplinary team, social work, specific social workers who are very similar to what Danny's a care coordinator individual does in terms of keeping track of what's going on, reaching out to these families. On the one hand, we could say, well, patients need to take their health into their own hands and they need to be their own advocate and so on. Well, if your family is working extremely hard, working 2 jobs perhaps, doing various things just to kind of keep food on the table, trying to get your school and everything else, then it's difficult that a family that is very resourced and perhaps has 2 parents and 3 nannies to kind of help them with keeping their lives organized. I think in the medical system, we can play a role, and we do play a role, and have gotten better at playing a role in reaching out to these families through folks like social work. The other one that comes to mind are the advanced practice providers, nurse practitioners, physician assistants. We've had significant growth in our department here in Chicago with that level of care provider really taking on coordinator and leadership roles within our multidisciplinary clinic and trying to keep the ball rolling, so to speak, and keep track of follow-up, keep track of compliance, keep the physicians organized, remind us, which patients we have coming up, what do we need to do to manage and keep track of, a lot of different things going on at the same time.
One specific finding that I'm still chewing on, I'm still thinking about what we do with it, how we contextualize it, and what it means, was we found that for increasing social vulnerability index, patients with rhabdomyosarcoma, were less likely to receive surgery. Now, the decisions around whether or not to have surgery for rhabdomyosarcoma in children are extremely, extremely complicated. But in general, smaller tumors that are more favorably located are more likely to have surgery, whereas larger tumors or tumors that are in unfavorable locations are less likely to have surgery. And so it's hard to see, other than the size of the tumor, it's hard to really predict why patients would have less access to surgery unless potentially the systems that they have access to are differentially considering the use of surgery in treatment paradigms. And so I think that what I take home from that difference is that potentially the different social vulnerabilities are giving access to different levels or paradigms of care that more or less incorporate surgery. It's one of the potential issues. Now, the other potential is that just the patients are presenting with more advanced disease that is not amenable to surgery, disease that is distantly metastatic, for example, where surgery would become, which would put them in a higher clinical risk group, in a higher or less likely to use surgery up front. That is a specific finding that I am still chewing on and talking to our oncologists about, is why is that the case and what does it mean for us in the care of children with rhabdomyosarcoma?
On that note, when I saw that finding in the paper, I agree with you. I assumed it was because a lot of these kids are presenting later because they're more vulnerable and don't necessarily have access to even a primary care physician to be referred to a big center where this kind of treatment does happen. So we did a much smaller scale study at our institution on something very common to otolaryngology is tonsillectomies. And we found that transportation, not even socioeconomic status, but access to transportation led to worse outcomes in terms of missing doctor's appointments, higher bounce backs to the EDs because they couldn't get to the doctor in time, and that led to dehydration and admission. So what we instituted is actually all of the patients that we assess for transportation issues. That's one thing, is we make it a point to assess for social disparities at our initial appointment. And the other thing is they have more frequent doctor visits scheduled. They don't necessarily, if they miss one, they don't have to wait to go to the end of the line to get another one. So for example, if I do a tonsillectomy, I'll schedule them 2 appointments, one at 1 week post-op, one at 2 weeks post-op. And even in cases where they don't necessarily need to stay overnight, I will keep them overnight to prevent bounce backs to the ED so I can make sure that the families are ready to go home. Now, that's a much more scale study than what we're doing. So how do you think the future, what could we do in the future to address these more challenging cases across a bigger community spectrum, not just within our local communities?
I think it's a devoting resources to an issue, recognizing it as an important issue, the transportation, the follow-up. Again, as you were talking there, in my world, I have a couple of social workers that come to mind who focus on our otolaryngology population. They're in our division, but just by the nature of where they're needed, they end up spending a fair amount of time with the more complicated patients, like the aerodigestive patients, which is a population also known to have many higher social vulnerability scores than some other populations, and also the head and neck cancer patients that the three of us here manage. But so having the resources of the social workers, hospital-based systems where we can tap into transportation programs, think about like us, like now, if you want to get somewhere, there's so many ways you can transport yourself on app-based programs, Uber, et cetera. So if we have the vehicles and the wheels to move people, but when you're moving patients, it's different than just you're an otherwise healthy person going to the supermarket. But are there ways that we can really tap into technology to be able to leverage the mass transportation that we do have to really just make it easier for patients to get where they need to be?
That's a really tough question, which is why I think none of us have answered it perfectly yet, although we're starting to see small changes. The thing that inspires me about the transportation issue is that if you look at disparities in adult cancers, there's great literature showing that a lot of those disparities fall out and cease to lead to differential outcomes in our local VA system, where we have spectacular transportation networks to get our veterans from our region down to Houston for their head and neck cancer care. And so, we would expect to see some of these disparities in outcomes for people who live far, far away or have no cars, but there's an incredible van program in the VA that brings the patients to their visits, and they have great care coordinators helping navigate them through the system. And I look at the VA cancer care system as a shining light for what could be if we could figure out how to mobilize the resources for cancer care in other settings. I think that when I consider my general referral area, I think a lot about some of our patients who come from limited medical resource areas in Southwest and South Texas. And there have been some really great partnerships that have formed between our surgical oncologists here in Houston and oncologists down in what we call the Rio Grande Valley, the valley in Southwest Texas. And we have had to try to increase communication between the groups in a regular fashion and have just taken small issues at a time to try to help get the patients the appropriate care in their community instead of having them make the 6-hour trip up to Houston. So, for example, I know that one of my colleagues is a pediatric surgical oncologist in orthopedic surgery, has worked hard on biopsy technique and modality with the local centers there down in the Rio Grande Valley to try to change the biopsy techniques and extent of biopsies in pediatric osteosarcoma, which has a huge impact on diagnosis and subsequent treatment in that patient population. And I know it's not an easy thing to work on, but she is having a lot of success with her collaborators who actually work in practice in the valley in getting the most up-to-date care into the local communities. On the other hand, I can think of some disappointing times where disease state has been appropriately identified for a patient down in one of these communities or in far West Texas, and an appropriate referral has been made. And for a ton of issues, it just takes the patients forever to be able to get to Houston for their care. Very family-specific factors. And I think that we have very realistically in individual cases seen care delayed. And so I will just say, Tony, we don't have a perfect answer to this yet, except to be aware to it, to try to transition care into the local communities when possible, to collaborate with those providers when possible. And I will also say that a lot of the work that is going to be required to make a difference in this is not traditionally reimbursable work for the healthcare system. And I think we all have to be honest about that some of the work that's going to be required to improve outcomes is not the type of work that the system can cannot bill a provider for. But it's an amount of collaboration and amount of coordination that has to happen to drive care forward. And that is also not an easy fix. We have to be realistic about the resources we have.
Definitely a challenging topic. And my final question is, what's next for the group? What are the next areas of focus in terms of research and how to drive this topic forward?
Well, my next focus is to convince David that you guys are idiots, so that he'll come to you for residency.
I think we need to keep doing what we're doing. Right now, I feel like we're defining the landscape. We're doing these social vulnerability studies, these SVI studies, looking at the different tumor types, and we've done the pediatric tumors, we've done the adult tumors, we've looked at some specific tumors in general. I think from the field of pediatric head and neck cancer, we're getting to the point where we're close, but not quite there yet, of defining what the variables are. And then I think we transition into looking at the various variables that are most associated with poorer outcomes, and we start looking to see what we can do about it. Is it still, just a matter of like improving transportation? Is it, education with different, ethnic backgrounds? Is it language? What are the factors we can, or is it a resource financial issue? I mean, like Danny mentioned that there are some things that need to be done that can't be specifically billed for. But does everything need to have like a billing code to be able to done, or do we start looking at things kind of holistically? If we're just taking care of patients and here's the money that comes in for that, can we make good delivery of health care not be restricted by finances? Can we be creative with how we structure the business, if you will, similar to how other businesses have to structure themselves to maintain appropriate profit, et cetera, that they can keep the whole enterprise moving forward, with support from federal dollars, et cetera, without that constant feeling of, well, can we bill for this? Can we bill for that? So looking at the finances of it, the overall structure of it, how our insurance system is organized, how we deliver healthcare to start to figure out how we can impact some of these associations that we're seeing, with our studies.
I think to borrow from another one of my areas of work, I'm the coordinator for the American Academy of Otolaryngology's annual meeting. And about 8 or 9 years ago, my predecessor, Dr. Mark Wax, included a question in the Call for Science submission for presentations at our meeting about whether or not there were women involved in the faculty for a particular presentation. And by asking that question, every year, we have seen that increasingly the proportion of presentations that have women faculty members has increased, and it's increased dramatically, and it's been year over year. We've started asking the question similarly about URM faculty members, underrepresented medicine faculty members, and those who represent other groups that have traditionally not been well represented enough in our educators in medicine. And it is not exclusively because we're asking the question that we're seeing improvements, but if we ask the question, people have to think about it. The people submitting presentations have to think about who their faculty are and if they are taking an equitable approach to who they invite to be part of their presentations. So we've been asking the question and we're seeing improvements in the representation amongst our faculty. Well, I think we have identified, and we've said this, across broad populations, some social vulnerabilities that we know across a broad population are going to impact care. So now we have to, I think, transition, and the next step is to very granularly start asking those questions of each individual patient that is coming to us. And if we are asking the question, then I trust that the whole system is going to drive towards making improvements because we're focusing on asking the question at the individual level. So that's where I think the most immediate application of this is for us, is to start really surveying for these social determinants on an individual level with the new patients that are coming in. And I believe that will help our care systems focus on relieving the inequities associated with those social vulnerabilities in terms of access to care and longitudinal surveillance, things like that.
That is a great answer from you both. Well, unless you guys have any final comments, I think we're ready to wrap it up.
Well, I just thank you, Tony, for stepping in as host and being a great partner in all this work. And likewise, Danny, you as well. And thank you to BackTable for having us back again. It's been a pleasure.
I hope you all enjoyed joining us here this afternoon. You can find us on SoundCloud, Spotify, and iTunes, amongst other podcast sites. Please follow us on Instagram and Twitter @_BackTable ENT. We love feedback. If you have any topics you're interested in hearing, please email us. Any ideas, speakers, and if you ever want to come on the show. So thank you very much, and we'll see you next time. Take care.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz.
with support from
Taylor Spurgeon-Hess and Ivan Orgodzinsky.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.